This is part 2 of the audio lecture on vital signs. In part 1, we discussed the importance of vital signs, and we also discussed temperature as well as pulse. In this part, we will be talking about blood pressure and respirations. At this point, you've probably had your blood pressure taken at hundreds of doctor's appointments. You've also probably practiced taking blood pressure on your classmates in other labs and courses. We're going to continue to practice and go over blood pressure because it is one of the biggest vital signs that has skill decay. So if you don't continue to practice it, you're not as proficient. When we're looking at blood pressure, it's represented by two numbers. The first number is our systolic blood pressure, and our second number is our diastolic blood pressure. Our systolic blood pressure is how much pressure blood is exerting against the arterial walls when the ventricle contracts. Our diastolic blood pressure indicates how much pressure blood is exerting against the arterial walls while the ventricles are recovering. We have 5 main blood pressure ranges. The first is normal blood pressure, which is approximately 120/80 or less than that. Blood pressure can get too low, but we want to be right around that 120/80 range. Between 120 to 129/80 is our elevated blood pressure, and then we've got 3 steps of hypertension. So hypertension is usually between 130/139 over 80 to 89, okay? When we're looking at our blood pressure, the 2 values that are recorded during the measurement of blood pressure are based off the appearance of our Kirchhoff sounds, which signifies our systolic blood pressure, that first sound that we hear through the stethoscope, and then when those sounds cease is our diastolic blood pressure. When we're taking blood pressure, we want to think about our patient positioning prior to taking it. It's also helpful to be in a quiet area so that you, as the assessor, can hear better. We want to make sure that the selected arm is free of clothing. It is preferred that we take blood pressure on the left, but we can take it on the right. But we should not take it through any sort of sleeves or clothing. So short sleeves is required. We want the brachial artery to be at approximately heart level. So we don't want their arm hanging super down by their side. And then we want to rest their forearm on something. That could be your other arm or a table or a desk or something like that. In terms of clinician setup, there are some things that we want to be aware of. We want to make sure that the equipment is clean prior to applying it to our patient. We want to place the sphygmometer or the cuff around the upper arm. The lower edge of the cuff should be approximately 2.5 centimeters above the elbow crease. A lot of the cuffs have an artery indicator tag. You want to make sure that that is over the brachial artery. And then when we fasten this cuff, it needs to be snug, but it should still be comfortable on the patient. You need to position the dial so that you, as the assessor, can easily see it. And then you need to ensure that the valve on near the pump is closed, and you ensure this by turning it clockwise. And then you want to take your stethoscope, put it in your ears, and place it lightly over the brachial artery. So it should go under a little bit of the sleeve. Blood pressure is measured in millimeters of mercury. That is the output. So that is the unit for each tick mark on the dial. When we're taking blood pressure, we want to inflate the cuff to approximately 200 millimeters of mercury, and then gradually deflate the cuff by turning the valve in a counterclockwise direction but this should be done slowly. It should be at a rate of 2 to 3 millimeters of mercury per second. So each tick mark so when you're deflating, it should be 2 to 3 tick marks a second. When you're taking your blood pressure, you want to listen for the first beat and note the numerical value on the dial when that beat occurred. Continue to deflate the cuff at the same rate until those sounds disappear, and then note the value when the sound disappeared. Once that sound has disappeared, you can release the rest of the air. So that first sound, when the sound appeared, is going to be your systolic measure, and that number where the sound disappears is your diastolic measure. Our blood pressure can be broken up into 5 phases. These are sometimes referred to as our Kirchhoff sounds. So phase 1 is that faint but clear tapping sound that gradually increases with intensity. Phase 1 is where we get our systolic measurement from. Phase 2 is our dampening of this sound that may be heard like blowing or swishing. Phase 3 is a sharper sound that returns, but it doesn't have the same intensity as phase 1. Phase 4 is well-defined muffle sounds that progress to become soft and blowing. And phase 5 is our absence of sound, or our diastolic measurement. This is a visual representation of those Kirchhoff sounds and what is happening in the rationale throughout each of the phases. This video further breaks down the Kirchhoff sounds and the phases. This is a picture of our sphygmomanometer, which we use to take our blood pressure, also known as our blood pressure cuff. On the picture on the left, you can see that there's 2 arrows, one that says left arm, one that says right arm. That arrow indicates on the respective arm where the brachial artery should lie. On the right, we have a picture of our dial. Each tick mark is 2 millimeters of mercury, and then the numbers represented by 20. So each longer tick mark between the 2 numbers is for 10. Because this is represented as each tick mark is 2 millimeters of mercury, we should not get odd numbers when we're reporting blood pressure. This video breaks down most of the things that we've talked about, but is a good reference if you need further help. This video talks about the 2 different sides of the stethoscope. We have the bell side or the diaphragm side. You can use either one to record blood pressure, but some people have different preferences. This video is mostly audio and it uses an amplifier so you can hear the different sounds that occur when you're taking blood pressure. I would highly recommend watching this video so you know what to expect. Moving on from blood pressure, we're now going to look at our respiratory rate. This is the number of breaths per minute that one takes, or the rise and fall of the chest. If you look at the table on the right, we can see that those between 18 to 70 take approximately 12 to 20 breaths per minute, and those between 6 and 18 take 15 to 25, and then we can also see older and younger on that table. Much like when we assessed pulse, when we're looking at respiratory rate, we can not just look at the rate or the quantity, but we can look at the quality of the breaths as well. When we're watching somebody breathe, we want to see, are they using accessory muscles? So we expect the chest to expand and contract and a little bit of rise and fall, but does it look like we're using additional muscles to assist with breathing? Are they able to take deep breaths or are they shallow? What is the depth of their breath when just breathing normally? One of our biggest indicators for quality of respirations is their ability to talk. If somebody can't talk, they're potentially in respiratory distress. And then when it comes to our quality, we also have tachypnea and bradypnea. Tachypnea is abnormal rapid breathing, and bradypnea is abnormal slow breathing. When we're assessing breaths, we want to observe somebody breathing for a full minute and count the respirations that they take. Unlike pulse, where we can multiply the breath rate, we do not want to do that for respirations. We want to record and watch them breathe for a full minute. The last vital sign that we're going to talk about is pulse oximetry. Our pulse oximetry, or sometimes the tool or instrument is often shortened to pulse ox. It's a non-invasive monitor that measures the oxygen saturation in the blood by shining a light at a specific wavelength through the tissue. This is usually applied to the finger. It's comfortable. It just kind of clamps to your finger lightly. And we're looking at our deoxygenated and oxygenated hemoglobin, two of the components of our blood, and they absorb light at different wavelengths. The absorbed light is processed by an algorithm and the pulse oxes to determine the saturation value. So we want a norm value, or a pulse ox value should be 95 or higher. If it's lower than 95, we are concerned. This was a common thing, especially with COVID patients. We're having decreased pulse ox values. We do have some issues that can skew our readings on a pulse ox. Because they're often applied to the finger, things like nail polish, excessive shivering or shaking, or excessive skin temperature or skin thickness like calluses can impact the ability to get an accurate reading. So it is something to keep in mind when you're applying a pulse ox to a patient or client. That concludes our lecture on vital signs. Here are some additional resources that you can peruse at your leisure.